So here at Merwick, we use the ReDS device in our cardiopulmonary program. We use it for patients with history of heart failure that come into us for the rehab stay. It gives us a sense and a guide of how wet or dry they are coming in from the hospital, since we're just meeting them for the first time. We use it once a week on our stable patients and more often on those that we're titrating medications on. And it gives us an immediate reading and guide in terms of how aggressive to be with their treatment versus waiting for a chest x-ray or some blood work. It has helped us reduce our readmission rates and also has helped us diagnose new patients with heart failure that perhaps had risk factors, but not necessarily the disease process, that have acutely decompensated in-house. And we've been able to manage those patients aggressively in-house with the use of the ReDS device. Using the ReDS and having it available in the skilled nursing facility and the long-term care facility really plays an active role in what we're able to do here and how aggressive we are. Because we don't have immediate x-ray results or invasive monitoring here, the ReDS gives us a value. We use it as almost our fifth vital sign in terms of our heart failure patients to get the information that we need immediately and act upon it. And through our experience, we've been able to prove the accuracy of the device, and we trust it very much. Since we've acquired the ReDS and opened up our cardiac program, in the past 7 months, out of 100 patients, we've only had 3 readmissions for heart failure, and we feel the ReDS plays a part in that number. We've also ranked with CMS number 13 in the state for reduced readmissions. And we feel with our clinical capabilities here at Merwick and with our cardiac program under the direction of Dr. Weisvogel and Dr. Sadhu, and as well as the ReDS device, all of that together has really made those results possible. A great example of the ReDS device here in our facility with a long-term care patient who did not have a history of heart failure. I got called to her room for acute onset of respiratory distress as she's sitting over her breakfast tray. So the easy assumption was that she aspirated, and we started treatment for that with nebulizers and oxygen support, but she was not getting better. So we were able to bring the ReDS machine in, which gave us an elevated reading, which was her first diagnosis of fluid volume overload. And it was also followed up with a chest x-ray and blood work that also supported decompensated heart failure. But because I had the ReDS at the time, we started IV Lasix right away and some BiPAP, and she was able to turn around within 4 hours and stay in our building. And not only did that happen once with this particular patient, but twice. We were able to save her admissions with aggressive diuresis because we had the ReDS reading in the setting of her respiratory distress.